Guillain-Barré syndrome and the role speech-language pathologists would play in the acute care setting by Nicole Campbell. The purpose of this presentation will be to discuss how Guillain-Barré syndrome presents in an acute care setting and how a speech-language pathologist would treat the deficits that may arise. Literature was researched to get a relevant understanding of GBS and the clinical implications that arise with the diagnosis. This literature is used to guide educational clinical decision-making. Speech-language pathologists play a critical role in the treatment of patients with Guillain-Barré syndrome in terms of swallowing and communication needs. Dysphagia and dysarthria are two common deficits that occur throughout the course of GBS. And to conclude, a thorough understanding of the clinical implications of Guillain-Barré, which lead to the most effective and beneficial treatment for your patient, is imperative. It is beneficial to instill the ACM model with treatment for best patient care. What is Guillain-Barré syndrome? Guillain-Barré syndrome is a rare autoimmune disorder. The immune system attacks healthy nerve cells in your peripheral nervous system. The cause of this condition is unknown, but it is typically triggered by an infectious illness such as the flu, gastroenteritis, or a lung infection. This suggests that an improper immune response is happening to this previous illness. Your muscles do not respond to signals that they receive from your brain, and it results in muscle paresis or paralysis. Some symptoms are difficulty with muscle movements, loss of bladder control, difficulty breathing, and paralysis, and they evolve rapidly. It affects 1 in 100,000 Americans and is more common in the older populations. Guillain-Barré syndrome has many subtypes, which makes it very complex to diagnose. Acute inflammatory demyelinating polyneuropathy is the most common, and that first attacks Schwann cell surfaces. Next is the acute motor axonal neuropathy, which first attacks at the motor nodes of Ranvier. Next is motor sensory neuropathy, which is the same as the acute motor axonal neuropathy, but it attacks the sensory nerves and roots, and the axonal damage is usually pretty severe. Last is the Miller-Fisher syndrome, which is very rare and few cases have been examined, but it resembles the same symptoms as acute inflammatory demyelinating polyneuropathy. To the left is a nice figure that describes symptoms and signs, and also involving frequency, of demyelinating Guillain-Barré syndrome. Research done by Crawford and Dearmum shows that individuals with Guillain-Barré syndrome have sudden onset polyneuropathy, which is characterized by muscle weakness, which occurs because of the damage to the peripheral nervous system. Symptoms usually develop between a few hours to a fortnight. Initial symptoms shown during the acute phase are as follows: irritability, behavior change, unusual sensations and pain in the limbs, often followed by weakness. These are all important symptoms to take note of when being admitted to the hospital and helps to diagnose correctly. There is also no cure for Guillain-Barré syndrome. Diagnostic qualifications are strongly based on history, clinical assessment, and investigations to eliminate other causes of these symptoms. Because Guillain-Barré syndrome is not such a black and white diagnosis, you really have to delve deep into all the case history and everything about your patient before making an educated diagnosis. With literature research done by Rigidix and Klein, Guillain-Barré syndrome is a well-organized, acute, disabling neurological illness, and many patients with GBS become bedbound and require expert nursing care. This is crucial for us to note because that just shows another healthcare provider that we will have to be in tune with when providing services. A crucial step in preventative care for GBS is a bedside test for swallowing dysfunction, because aspiration poses a huge risk in these patients and external nutrition may become necessary. For intensive care unit management, the management of patient reflects on the unpredictable nature of GBS. That is why they are in the ICU, with potential for rapid deterioration and high chances of respiratory failure. It is important to know all of these things that can change quickly within this diagnosis so that you can act accordingly when developing your treatment plans and knowing what to assess. An important piece of literature that I came across in my research was an article written by Carly Stoltenberg, a speech-language pathologist who has first-hand experience with Guillain-Barré syndrome. She was diagnosed in 2018 and wrote an article to help those patients to get the most beneficial care. She noted that she had an NG tube for a while because it's less invasive, but it was painful and a hassle. So she switched to a G tube, which was less painful and more effective in getting her nutrients. This is something she would have done from the beginning, but through trial and error found was the most effective for her. Also, SLPs were giving her high-tech augmentative and alternative communication boards, but it might not be the best route for everyone. Carly herself experienced double vision, so using these boards was not helpful in facilitating communication. Providers should not automatically defer to family members in hopes to not let the patient lose their voice. Carly felt very distant with her diagnosis because she's found that a lot of medical professionals just bypassed her thoughts and went straight to her families. You have to understand the nature of GBS and be aware of the conversations you have around the patient. Positivity is key, and she experienced a lot of negativity due to the severity of her diagnosis that did put a damper on her motivation throughout her recovery process. And lastly, be diligent with insurance companies to acquire the appropriate care, such as an acute rehab facility. It is proper for you to use the right information to get to the right level of care. As Carly said, she had a lot of problems with finding the correct insurance information to include for her to be applicable for next level care. Structures and functions affected by Guillain-Barré syndrome. Dysphagia is often shown in those who suffer from GBS, which is a paralysis and paresis of muscles of the face. Facial dysplasia, which is paralysis of both sides of the face, is shown in about 50% of cases, and it affects all stages of swallowing, oral, esophageal, and pharyngeal, leaving the patients at a high risk for aspiration. Next is dysarthria, which can be a paralysis or paresis of tongue, larynx, and or vocal folds, affecting articulation, phonation, and respiration, leaving communication to a minimum. Nerve damage and muscle weakness are what are experienced. The cranial nerves that are often affected are the oculomotor, which helps control muscle movements to the eyes, trochlear nerve, which also involves in eye movement, trigeminal nerve, which is motor function is to control a person's chew and give sensation to the mouth, glossopharyngeal nerve, which controls sensory information in the throat and throat muscle movements, the vagus nerve, which does taste sensation, motor to the throat and soft palate, and parasympathetic functions, which regulate heart rhythm and innervate the smooth muscles in the airway, lungs, and gastrointestinal tract, and the hypoglossal nerve, which supplies motor nerve impulses to the tongue. With these cranial nerves potentially being affected, you can see how severe dysphagia and dysarthria can present in those with Guillain-Barré syndrome. SLPs play a critical role in the management of GBS-associated dysphagia. The goal is to mitigate aspiration to prevent aspiration pneumonia, which can lead to death. SLPs are also critical when developing the best mode of communication specific to each patient's ability. Understanding your patient's limits will help guide the most effective way to communicate. If they are able to blink and control their eyes, then an eye gaze system may be appropriate to establish some ability of communication until strength is regained. Some key aspects to successful management of communication and swallowing in the hospital settings are as follows. Thorough knowledge of GBS. understanding safety concerns with dysphagia and dysarthria, and knowing whether the patient is on a ventilator, intubated, and the rate of patient progression. This crucial information will guide your therapy sessions to become the most beneficial. Provide appropriate counseling and support for the patient and family. And understand that the doctors and staff all work as a team for the best patient care. Next, we will discuss the ACM model and how it may look when used to treat a Guillain-Barré syndrome patient. First, we will discuss clinical facts and service delivery model. It is crucial for you as the SLP to add your knowledge and education to help care for this patient. This can be done by answering the referral question on the patient's chart. For a GBS patient, it might look like, is it safe to PO feed this patient? Dysphagia is common in this diagnosis, so it is your job to do the proper assessments to answer this question accurately. An SLP may be asked to manage all of the swallowing and communication aspects of this GBS case. It is crucial to keep in contact with the medical professionals working on this case to track progression and be up to date on any patient changes. Next, patient and family wishes will be discussed. Make sure the patient and family understand the realistic nature of GBS. This can be done by educating them in simple terms for the most beneficial understanding. Be sure to compile patient concerns, if applicable, and family concerns. The SLP will address these concerns with honesty and empathy. Make it known that you are there for them, and facilitating positive change is the main goal for this patient. Next, psychosocial dimensions will be addressed. As the SLP, be sure to know the patient's story before their diagnosis. Their history can play a crucial role in their progression throughout therapy. A history of depression is important to note in GBS patients because the severity of communication and swallowing deficits could act as a recurring trigger for depressive behavior. This will affect patients' motivation in therapy. It is important to note this behavior when developing therapy sessions that would be appropriate and personalized. When the patient gets close to discharge, make sure to know patient's plans post-discharge. This will help guide next level of care and show if any areas of concern arise. Example, will be they living alone? Do they have a good support system? Lastly, ethics, quality, safety, and cost-effectiveness will be discussed. Ethical concerns may arise with the GBS patient due to swallowing insufficiency. It is your job as an SLP to make sure they are getting proper nutrition and hydration in a safe manner. Also, understand what the patient's support network looks like. We treat the whole patient, including the family and caregivers. Track the quality of this patient's care by being up to date on their progress and assessing if this is the best setting for them. It is also crucial to be aware of the patient's diagnostic-related group, because the time limit associated with their stay will add pressure to your treatment sessions. In conclusion, Guillain-Barré syndrome is a very complex diagnosis. Speech-language pathologists play an important role when treating patients with GBS. Safety, swallowing, and communication concerns are the main focus for rehabilitating these patients. It is crucial to get a thorough understanding of GBS and how it is progressing in your specific patient. The application of the ACM model provides patient and family-centered care that is a beneficial model to follow when treating patients with GBS.